Boom. Okay, so there's no KWL today because we have a lot going on. So good morning. We're gonna do a heart failure lecture, and then we're gonna do a concept map, which you guys should be pretty familiar from clinicals. We're just gonna kind of look a little bit more deeply into one of our patients. We're gonna have a little break. We might do more breaks. We'll kind of see how we're doing. Then we're gonna come back and do one of those new generation case studies that you guys can follow through all together. We're going to talk about hypertension and then do some medication work and then break up into our group projects. Any questions about the layout of today? No, it's going to be fun. We're going to bring out balloons. It's going to be all good. Which I forgot to, I wanted to draw a little heart. So I'm going to take two shapes just to draw a little heart because I always want to point to one and then I forget. All right. Oh, that's what you're talking about.
Yeah.
I was thinking something else. Well, I draw my heart. Bree was gonna make a quick announcement.
Okay. If I can just have your attention, please. Last night, I'm sorry to be so emotional about this, but last night my dad was in respiratory failure. I know I've talked last quarter about him having COPD and being one of one picture. Whatever your religion, spirituality, or juju or vibe that you can send out into the future, and send out into the world, we sincerely appreciate that. But now he's on BiPAP, he's in respiratory acidosis. He's in critical care. I just really appreciate that. Saw Sharita again last night. So, but yeah, anything would be much appreciated. Thank you. No problem.
All right. Well, don't mind my drawing skills. I'm sorry that they're a little bit subpar. Well, let me plug this in so I can use this guy. Okay, if you haven't joined the Minty yet, please go ahead and do so. And then would you give me a little like reaction so I know that you guys are in? You can do the QR code or enter the code at Minty. Perfect, okay. Anybody need this up so they can still join? Yes, okay, I'm keeping it. So heart failure and hypertension are another one of those disease processes that you guys are going to encounter, regardless if you're adults or peds, labor and delivery versus rehab. You're going to encounter people that have these disease processes. So most of them, and most of them are pretty universal, right? So if you're taking care of a pregnant woman with hypertension, a lot of the treatment and what we're trying to do is the same as anybody like an old, 90-year-old man with hypertension. It's the pathophysiology is very similar, and what we're trying to do is also very similar to control it. Anybody else still need this up? We all good? We'll keep moving on. Actually, before I move on, maybe I'll write down the number. That way I don't forget. What do we have? 8417. What are the rest? 9744. 8417, 9744. That look right?
Yes.
Ish. Okay. Okay, so hypertension. Heart failure. We're talking about heart failure first. So when I think about heart failure, there we go. So sometimes people used to call it congestive heart failure. That's kind of an older term. I kind of like to remind people of it because sometimes that helps people think about what's happening inside the heart where it's congested. There's usually with heart failure, there's too much fluid or too much pressure going on. I like to think about it as a dam, right? So our heart is this pump, right? All of the blood from our body, where does that go to from the heart when it's first coming to the heart? It goes into the right atrium, right? So it comes here, and from there, it flows to the right ventricle. Right, this is review. I know that Abby hammers this into you. Do you guys have to walk around, do the little heart walk with Abby? So then from the right ventricle, where does the blood go? Into the lungs. What's it doing there? Yeah, it's gotta get oxygenated. So then from the lungs, where does it come back into? The left atrium, down into the left ventricle, and then where does the blood go to? All the rest of the body getting pumped out. All right, so we kind of understand the flow of where blood goes to. So I think about this flow, like we have the heart that's pumping it, right? But this flow is kind of like a river. And heart failure is kind of where there's a dam. Something is damming up this river. And when we think about the different types of heart failure or the effects, what are the signs and symptoms? It all depends on where that dam is happening, right? So if we have lung disease, we've been talking a lot about lung disease lately, and somebody maybe doesn't have very good lung compliance, they can't breathe very well, maybe they have some COPD where they're not stretching as well as they need to. What's going to happen when all of that blood in the lungs, it's not able to move through like it should? It's gonna back up, right? It's that dam. So if it's in the lungs, where does it start back? If that's a problem, where does it start backing up to? What's that? Peripheral, but first, right, the lungs, where is it coming from, right? If we're looking at a river, we have to say, where's it coming from? It's coming from this right side of the heart, right? And it's gonna back up into the rest of our body. So on the right side of the heart, when it's having problems, it backs up the rest of the body. What does that look like? Yeah, usually edema. That's a lot of what we see. What about if somebody has a heart attack, right? They have a heart attack, it causes some damage to their heart. And maybe especially in this left ventricle. This left ventricle is damaged and it can't pump like it should. So thinking about our heart and the blood flow as a river, if our left ventricle gets damaged, where does the blood back up to? The lungs, exactly. So what do we see with patients and with that? Shortness of breath. Sometimes if we have a lot of fluid, we might see cough too. They're just trying to secrete it. If it's acute, if it happens really fast, sometimes we'll even see like pink frothy sputum. And we'll talk about that a little bit later too. So when we talk about the whole like heart failure, think about like this is blood flow and it's wherever it's dammed up at, then we're going to see all like, I like how it's like, you have the river kind of going here and then it's dammed up and it's like just kind of building. I think that's what happened is what's happening here. I feel like this is optical illusion. Like which side is the river? Like this looks like it's flowing, but this almost looks higher, doesn't it? Yes. Interesting. Because when I first looked at it, I thought this was the river and then this is where it was dammed up. So that should be lower, but maybe this is where the river is flowing. Oh yeah, because it's flooded up here. Okay, now I see on the bigger screen. Okay, sorry guys, it took me a minute. All right, let's keep going. So let's talk about different causes of heart failure. So coronary artery disease is probably the most common. Coronary arteries, they supply blood to the heart, right? So arteries, I was saying arteries away. They're pushing blood away from the heart. It's the oxygenated blood that's going out. Coronary arteries are what give the heart oxygen and the energy it needs to pump. So if somebody has issues with their coronary arteries, the heart's not going to have enough oxygen and be able to give the heart enough energy to pump. So if the heart can't pump effectively, what's going to happen? Maybe low saturated, we might see it. I just couldn't differentiate. Heart failure, maybe, or yeah, like the heart's not going to work as effectively, right? So depending maybe on where the coronary arteries are affected, we're gonna see blood getting backed up either in periphery, into the lungs. Cardiomyopathy. A little pointy guy working? Oh, not super well. What is cardiomyopathy? Yeah, the muscle of the heart isn't working as effectively, right? So our pump, if it's not able to pump blood through like it should, that blood is gonna back up. It's gonna be like that river dam that got kind of all backed up. Same thing with our heart valve disorders that we talked about last week. That heart valve, maybe if it's a stricture or if it's like, oh gosh, I'm blanking on the word, guys, I'm sorry. If it's really tight and it doesn't want to let blood flow through stenosis. Let's say we have some stenosis over here, right? That's going to keep blood in the chamber, right? It won't let it go through. Or if we have like regurgitation or something else, that's going to let blood back through. See, it's going to keep that flow of the river. It's going to be changing it. Same thing like we talked about myocardial infarction. Somebody has a heart attack, that part of your heart isn't going to be working as well. And so blood is going to back up from where it came from. So these pictures are in the week 9 resources as well. I don't talk a lot about preload and afterload, but you might hear those terms. And I love this picture because I think it makes it really easy to understand. Preload is the pressure at the end of diastole. So when the heart's kind of relaxed, that's preload. That's kind of the fluid that you have there when the heart's relaxed. Afterload, that's the resistance. So afterload is when this ventricle, which you can kind of see right here, or here's the ventricle. So when the left ventricle is ready to push out, afterload is that resistance it has to overcome, right? So what might be some things, I like how it has this little thing on here, scritching down. So something like vascular resistance, or if somebody has constricted, what is the word? I'm sorry, guys. Maybe I should look on the screen. It might have something here. Hypertension, that would be one. Oh, vasoconstriction, that was the word I was looking for. So, right, if somebody's blood vessels are constricted, they're smaller, they're going to have to work harder. The ventricle is going to have to work harder to push the blood out of the heart. And so that's what afterload means. I'm not going to get really big on that, but sometimes you'll hear those words in textbooks or other places, and it's nice to know preload versus afterload. All right, so each ventricle pumps equal amount of blood, right? Like all the heart, like all of the blood goes through all of the heart, right? It's not like it just that some blood goes to this area and this area. It's that all of the blood flows all the way through the heart, the right side to the lungs, and then to the left side out to our body. If we have more fluid or the fluid is backing up, then that's going to cause that heart to have to work harder. The heart's going to try to keep pumping to overcome everything, but eventually it's going to fail. It's not going to be able to do that job effectively. Usually the left ventricle is the one that kind of will weaken first. It's the one that's pumping things out to the rest of the body, but eventually the right ventricle will fail. If the right ventricle is the one that kind of gives out first and it's the one causing problems, or it's, failing, eventually the left one is going to fail. It's not because we talk about right-sided heart failure and left-sided heart failure. That's good. It lets us know how the body is reacting or the symptoms, but eventually it's going to be overall heart failure, because if one side of the heart is failing, the other side is going to fail too. It can't keep up the work of both sides together. So here's a little bit more about afterload. It's that force that you have to bypass. So things that are going to increase that the resistance are going to be high blood pressure. So the blood pressure might be high because of a few different things, right? If we have vasoconstriction, that's going to increase the blood pressure. If you have too much fluid, that's going to increase the blood pressure. Question for you. Oh, just kidding. I have another picture. Left-sided heart failure. And I like to remember the symptoms of right-sided and left-sided heart failure is that left side affects the lungs. So left side lungs. And so we talked about that, right? Like they're gonna have difficulty breathing. Their oxygen sats might be low. They're gonna, be more easily fatigued. So this kind of is a nice one that kind of shows what left-sided might look like. Sorry, Minty's been really slow lately. Nope. Oh, was there a question that was on there? Let me try to move through. Yeah.
There you go.
Myopathy, cardiomyopathy, the same as in the facility of the heart muscles, or those kind of different things?
Different. Cardiomyopathy is when the muscle of the heart is weakened and not doing as well. Cardiac like hypertrophy, and that's when the muscle is getting bigger. So the muscle usually, like there's a lot of maybe too much fluid going on, and so the heart's having to beat harder and harder. And so it's just like a weightlifter who's lifting more and more, heavier and heavier. And so that muscle gets bigger and bigger. It could lead to myopathy where the heart starts not working. Those muscles don't work as well, but they're not the same thing. Did we get this on here? Okay. So doing that question reading, like what is this question asking us? The nurse would evaluate the patient as understanding heart failure if they stated which. So we know that if the patient's understanding it, that's going to be a true statement, right? If the question had said the patient doesn't understand or the patient needs reinforcement, then we're looking for the wrong answer, right? The incorrect statement. But so this one, the patient understands heart failure if the patient stated which of these occurs to the blood flow through the heart. Maybe, do I understand this question? Yeah.
Cause I'm like,
Huh, well, let's see what the right answer is. Yeah, so I agree with what you're saying, that it could be, it depends on where it's backing up from. I think they're thinking if you have, it must have been a question about left-sided heart failure. So a lot of times when I'm putting these questions in, the questions that I have are like longer and I'm like, okay, how do I condense these to fit them onto the Menti? And I must have like took out a significant piece. So, but yeah, blood might back up through any of these. Usually, I'm wondering if usually it's talking about the left ventricle is the one that kind of gives out first. We see a lot of the problems, but yeah, blood's going to be not flowing like we want it to. So right-sided heart failure, it's trying to pump into the lungs, right? Cor pulmonale, that's kind of an older term they used to say for right-sided heart failure. Again, I'm not going to test you if you know what cor pulmonale means. It's just a nice word because especially when you're looking through history and physicals, like in your clinical, you might see some of our older providers write down cor pulmonale, and they're going to be talking about right-sided heart failure. So here, right-sided heart failure, and you can see how there's so much edema, especially in the bottom. Blood's backing up into our organs as well. And that's one thing I don't want us to forget, that, you know, our liver, our gut, all those things are going to be kind of, blood is going to be backed up. Because of that edema in our organs, they're not going to function as well as we want them to, right? So it kind of affects us all of our systems to some degree. So a nurse evaluates the patients exhibiting the classic symptom of acute heart failure if which of these occurs. Let me turn the sound down. No. No, this is just a choose one. So this one is a little tricky because I asked it before we talked about it, but acute heart failure. So when we talk about what we've been talking about is what we would kind of class as like chronic heart failure. People can also have acute heart failure, just like when we talked about renal and renal disease or renal dysfunction. People can have chronic renal failure, but they can also have acute renal failure, right? And that's reversible because of something specific that's happening, and we can reverse it, and then their kidneys can keep working well. The same thing with heart failure. You can have acute heart failure, and that's where your heart, or it's suddenly overrun with extra fluid because of something. And so if we can identify that cause, we can reverse it, and they don't have to have chronic heart failure after that. Typically, the classic hallmark sign of acute heart failure is pink frothy sputum. I think a lot of you guys heard me say that at the very beginning of class, and you're like, oh, I recognize that. She said that. And oops, I didn't do back, sorry. There we go. You were correct. Pink frothy sputum. Oh, did I put that? Okay, we're going to get into the acute heart failure in just a minute. So compensatory mechanisms. So let's talk just a little bit. When the heart is overrun, that dam has backed up all this blood, and it doesn't matter if it's on our left side of the heart or right side of the heart, the compensatory mechanisms are pretty much the same. The body's trying to compensate. It's saying, okay, we're backed up. What are we going to do to get all this fluid where it needs to go? So what the body's trying to do is to maintain, so normally you and I, we don't have heart failure. Our body's trying to maintain output or maintain our fluid level, kind of our volume at one level. There's several things that we have that help maintain it. So the sympathetic nervous system, right? We're going to go run up the stairs. It's going to say, okay, you need a lot more blood flow through your body. So I'm going to increase your heart rate, right? All of us, if we ran up these stairs over here, our heart rate would go up because our body's saying we need to get more blood to where we need to go. The renin, angiotensin, aldosterone system, sometimes they call this the RAAS system because it's a lot easier to say. That has to do with fluid balance in the kidneys and in the lungs a little bit too, about how we get rid of fluid. The chambers will enlarge in some cases, like we talked about with cardiomyopathy or hypertrophy, and then, dilation, and then hypertrophies or muscle mass increases. So with the sympathetic nervous system and the renin angiotensin aldosterone system, both of them are trying to help us maintain the fluid. So if they're like, okay, this left ventricle, it's got way too much fluid in it. It's getting backed up into the lungs. It might start pumping faster. So it's like, hey, I'm not getting all the fluid out like I want to. I'm going to get it out even more. Where our renin angiotensin system might not be working super well, we actually might give some medications that affect the system here that are going to affect pulling some of that fluid out so that we don't have as much fluid in our system. Okay, here's the acute heart failure. So this is severe congestion in the alveoli, those little sacs, those little air sacs at the end. Sometimes people say they're drowning in their own secretions because they feel like they just can't breathe. Eric was sharing about a patient he had recently that just can't breathe. You got to do something. Something is very wrong. And there's several things that can happen when people feel that way. Usually when I see people touching their chest, saying they can't breathe, feeling like something is really wrong, I usually think of either a heart attack, right? A myocardial infarction. I think about a pulmonary embolism, or I think of acute heart failure. And a pulmonary embolism is oftentimes what can cause acute heart failure, right? Because all of that blood trying to go through the lungs, it's not getting enough oxygen like it should. It starts backing up. And so you'll see these people where they just can't breathe. They start having so many secretions. They're breathing, but it's not effective, right? Because they're so backed up. They're restless, they're anxious. And really what we're going to do about it, well, we're going to probably do a couple of tests, right? We're going to make sure that we know that that it is a acute heart failure versus a myocardial infarction, right? So we might get some cardiac enzymes, and if they're negative, that's gonna say, okay, that's not a heart attack. But if we get ABGs and we're like, oh, those are all out of whack, we know it's probably pulmonary in nature. Probably going to get an X-ray too, see what's going on. And then our treatment is going to be designed around trying to figure out what caused the acute heart failure and seeing if we can correct it. A lot of it for nursing care, we're going to try to be supporting them, right? We're going to go in. Are we going to put them into the Sims position? No, right? Because what is
Yeah.
Sims position?
And
It's
if
laying
we're
on your side, right? We're gonna get them upright, right? Upright. We might give them some oxygen. We're gonna call for help right away because acute heart failure is a critical issue. That's something that we need to address right away. Because if we don't, their lungs are just gonna get just even more flooded and they probably will pass away. Some of the medications they talked about, we might give diuretics, which we would give diuretics in heart failure in general. What do diuretics help to do to that dam? Yeah, it's going to decrease that overall fluid. So if that dam is getting like backed up, if we can decrease the overall fluid volume, that's going to help decrease some of that pressure on those areas. Vasodilators. What will vasodilators do to that backup of fluid? Kind of, but what vasodilators, so everybody kind of hold up, like if you have this is your blood vessel, right? How much, like kind of imagine how much fluid can go through this big blood vessel right here. Moderate amount. If I close up that blood vessel, can as much fluid go through?
No.
What about if I open it up really big?
Yeah.
A lot more fluid can go through. So vasodilators dilate all your blood vessels and that lets more fluid go through. So it's getting rid of that backup of fluid that's either in your heart, in your lungs, in your peripheral, wherever it's at. Inotropes, those usually help more of like strengthen the contraction of the heart. So specifically when we're thinking if blood is backing up, you know, if our left ventricle can be stronger and push out that blood more effectively, then we're not going to have it back up through the rest of the heart. Okay, good question. Okay, so the nurse is contributing to the plan of care. Which of these nursing diagnoses would the nurse include? It's got to be for heart failure because I didn't put that in there. Sorry. And it says select all that apply. I'm sure it probably won't let you select all that apply because Menti and I are still in this battle over trying to let you select all that apply. All right, so impaired gas exchange, great job. A lot of people got that one, right? If fluid's backing up into the lungs, we're not going to be able to exchange air like we need to. Might not get rid of carbon dioxide or get that oxygen. Decreased cardiac output. Yeah, if our left ventricle is failing or fluid is backing up over here, we're not getting as much fluid over here to be able to get out to the system. So that's going to be decreasing our output. Good job. Chronic pain would not be one that I necessarily relate to heart failure. Anxiety though, especially when we think about fluid backing up into our lungs. Anytime that our breathing is impaired, and what I mean is by humans, tend to get pretty anxious. In fact, whenever somebody's having any kind of pulmonary issue, that's one of the signs and symptoms they're looking for. Anxiety, restlessness, kind of something seeming just generally off with them. That indicates usually something pulmonary because it's usually about oxygenation. And then fluid volume deficit, not so much. What would it maybe be like? What about fluid volume overload? Yeah, they have too much fluid. Yeah, so some of the diagnoses, impaired gas exchange. Okay, we just talked about that. It could be, did they say acute pain on this last one? Is that chronic pain? Okay, I was gonna say, it could be acute pain. You know, if there is an issue, it just depends on what everybody's symptoms are. I would say for heart failure, the decreased cardiac output, fluid volume excess, impaired gas exchange. Those are more ones, nursing diagnosis that I would associate. So chronic heart failure, it's usually not reversible, right? That acute heart failure, the pink frothy sputum, it's an emergency, we can usually reverse. If we can reverse the cause, we can reverse it. But with chronic heart failure, we can't reverse. You want to treat the cause, you want to see what's happening, like what's causing the body, how this back up with it. If we can treat it, we can slow the progression, but we're never going to be able to actually get rid of it. And they're probably going to get worse over time. And that's why the older you are with heart failure, usually the worse you are, because usually you've had it for longer. So some of the chronic signs and symptoms, fatigue, weaknesses, sorry guys, exertional dyspnea. That's kind of a trick. What does exertional mean? Yeah, like when you're doing something, if you're running up the stairs, you're exerting yourself. Okay, we're all going to be a little dyspneic, right? A little bit of trouble breathing going up the stairs. But these people with heart failure, especially if it's advanced, they're not going to be able to even run up a couple stairs. They're going to be like plodding up, and they're going to be taking a few breaths in between because they just can't tolerate that. They might have cough, crackles, and wheezes, especially if it's affecting the lungs, edema. I did put up here the acute heart failure signs and symptoms. So I think it's nice to kind of compare them side by side. If you get like a test question, is this acute, is it chronic? So the acute really is affecting the lungs, right? The chronic, there you go. It might affect the lungs, right? But it's also where you have so much fatigue. You have anemia, edema, malnutrition, like you have these long-term issues with the chronic heart failure. So think about, acute heart failure, really just it's a sudden issue where the lungs are being overflooded. And the chronic heart failure in general is going to affect the lungs, but it's going to affect the rest of the body and the rest of your systems as well. Some complications, just like we talked about, it's gonna affect the rest of the body. They might end up having pleural effusions, right? From all that extra fluid. It might even accumulate around the lungs. They're at more risk of having an emboli or a blood clot form. A lot of that's from blood not moving as effectively as it should, right? When blood's not pumping and moving as well, it tends to clot up a little bit. Eventually, they can go into cardiogenic shock. Boom, boom, boom. All right, so if we're looking at lab tests for a patient who has heart failure, which is the most important that we report? And I guess I'd say important if it's elevated, looking at heart failure. All right. I think I maybe misspoke because I said which is important if it's elevated. And really what the question is saying, when you're looking at somebody with heart failure, which is the lab that lets us know about heart failure? And that lab is BNP. If you had an elevated troponin, yes, you would let the provider know. But that's not, what does an elevated troponin tell us about? A heart attack, really. Yeah. It lets us know that the heart muscle is dying or injured. There's something wrong there. But the BNP serum, it's the binatric peptide, bitype. Anyway, I always say BNP because it's so much easier. Your heart produces that. When your heart is having to work even harder, then your heart ends up producing more and more of this BNP. So I don't remember the exact normal range. It's like 2 digits, I believe. I've seen it where people are in the thousands because their heart failure is so extreme. When people come in, especially into urgent care, ER, hospital, if they're in a heart failure exacerbation or that's like really affecting them, we always want to look, so what's their BNP? Because that lets us know how hard the heart has been working to try to get this fluid pumped through their body. So like I said, sometimes in the thousands, it gets so high. And you're like, wow, your heart is working really hard. And so we want to make sure that our providers know, because that lets us know, okay, this is a heart failure issue for sure. Okay, so some of the diagnostic tests, we're going to be looking, like I said, the BNP, that's the hallmark of like, how is their heart failure doing? Probably want to get a chest x-ray. We want to rule out other issues as well, right? So that's why we're going to look at the heart, some other, we're going to look at the heart too, but we're going to see, is it the heart that's causing the heart failure, right? Like, is it something acute happening, or is there something chronic otherwise going on? And what I mean is, let's look at this as an example. So sleep study. Why would we want to get a sleep study on a patient that we're worried about having heart failure? Sleep apnea, yeah, because we know that if somebody has sleep apnea, they are at much higher risk of developing heart failure as well. You're putting a lot of stress on your heart when you have sleep apnea. So we might be doing some other examinations or other tests to say, okay, maybe we want to do an exercise stress test. Maybe there's some damage going on in the heart that's caused the heart failure. So we're gonna do probably a whole bunch of tests. Please know the BNP is the one, the lab value that you need to know what your patients have when they come into the clinic or hospital. So our goal is to improve the function of the heart, right? We want to decrease that volume if that's the problem, or just increase the ability of the heart to pump through. We want to try to make it easier for the heart in general, right? The heart is having trouble. The heart's tired. We want to try to ease that workload. So we're going to probably give them medications, and we're going to talk more about these medicines in a little bit later. We're also going to do oxygen, most likely, because if it's affecting their lungs, they're going to need some supplemental oxygen. And the medicine I didn't talk about in the medication activity is anticoagulants. Why would they need anticoagulants? Right, they're a higher risk of having thrombosis. Doesn't mean that every patient that has heart failure is going to be on an anticoagulant, but you're probably going to see several heart failure patients who are on anticoagulants because they're a higher risk of having those thrombosis. And we don't want it breaking off and traveling. Where are the 3 areas we don't want it to go? Heart, brain, and lungs. Those are our 3 big areas that blood clots travel to. And what are the medical words? What's the one for the blood clot to the brain? A stroke. Yeah, it'd be an embolotic stroke. Lungs, what's it called? Pulmonary embolus. And then to our heart, like a heart attack. Yeah, myocardial infarction. Bum, bum, bum. The book talked a little bit about ventricular assist device and artificial heart. Just know when somebody's heart is like really pooping out, not doing well, eventually what they're going to do is say, okay, your heart is not compatible with life. If you want to live, we're going to have to do some different things. Sometimes they'll talk about transplantation. You could have solid organ transplantation, like a new heart. If somebody's waiting for a heart, or if that's just not a possibility and they want to buy a little more time, sometimes they'll use these assistive devices or kind of just help them get to, the next stage of life until they're ready to kind of move on. If that makes sense. I'm not going to get big into it because I'm not going to test you on the ventricular assist devices. They might do some valve replacements or reconstruction, right? So if we know that part of our issue with this dam backing up is because our valve is malfunctioning, we can fix that. We have surgeries that can. We might not go and do surgery right away. We might try some other therapies, but we might go in and do surgery on that. If it's part of the heart, maybe one of these ventricles, especially this left one, is hypertrophy. The muscle got really big because it's just working really hard trying to pump that blood out. Sometimes they go in and kind of shave off some of that muscle because it's occluding, like this muscle has gotten in hypertrophy. The muscle has gotten like big and fat, and it's all taking up this space because it's trying to pump the blood out. But what happened to the available volume that this can handle now? Good. There's not very much this left ventricle can pump out. It's going to be more effective at pumping it out because it's stronger, but it doesn't have very much in it. It can't. So they might go in and kind of like remodel some of this and take off some of that muscle just so they can open up some more space in the ventricle. So some other of the nursing diagnoses we might see: impaired gas exchange, decreased cardiac output, acute pain, anxiety, excess fluid volume. I feel like this is the same one we just talked about. We talked about some of our nursing interventions, some things we're going to do to also help our patients. Fluid management, that's one of the big ones. If we have fluid that's backing up, we're going to teach our patients that they need to help us maintain that fluid balance. Anybody ever taken care of somebody on a fluid restriction before? Anybody felt really successful with that? I've always felt like it's a fight, because usually people with heart failure, A lot of times we go on a fluid restriction, where we say, listen, your heart is not doing great pumping the amount of fluid that it has. We need to try to decrease the amount of fluid that you have. And so we'll say maybe you have 2 liters of fluid per day. That's all you can, or maybe 1,500, or maybe 1,000, sometimes 800. The extent of the heart failure kind of tells us how little amount of fluid they can have. And the thing about it is, when you say, okay, you can have 1,000 milliliters of fluid for the day, that's the whole 24 hours.
Yes.
And that includes things like ice, your soup, their coffee that they want to have for breakfast and lunch and then after dinner. Like all of those things. When you have somebody on a fluid restriction, that gets really hard because those patients, they went from being okay to being like, the only thing I can think about is wanting to drink more fluid right now.
Yeah, they get really upset.
They do get
They
really
don't-
upset. Yeah, it's
So
really
then-
hard. And
so-
so,
Question.
Yeah.
So they won't get dehydrated even though they just.
no, and why won't they get dehydrated? That's a good question. Yeah, they already have so much fluid. They might feel thirsty, but it's not because they're dehydrated. These patients usually have a lot of edema. And some of our goals of treatment, we're trying to shift that fluid back into their vascular space. Because if their fluid, if they might have several pounds of fluid in their feet, right? And so we want to move that fluid from the cellular level and the feet back into the blood vessels. So what kind of things are we going to do to try to shift that fluid from the feet back to the blood vessels? Yeah, we're probably going to raise up their feet, right? We want to get them moving. Movement is really good. But then my patients that have a lot of extra fluid and swelling, as soon as they're done walking, I'm like, back to bed, back to the recliner, get your feet up, because that's going to help get the fluid back into it's going to drain it back into the blood vessels, essentially, not let it pool there on their feet. And so a lot of this is teaching. A lot of this is teaching and like to help them understand. And what that means is, what I mean by that is compliance. Because if you can teach somebody, this is why we want you not to drink very much, because then you can't breathe. Then you get swollen. Then all of these things happen. If they can understand the why and they can buy into that and say, yeah, I get that, they are so much more likely to follow that at home, right? And that's what we want. We want them to be able to manage their symptoms at home. We're also going to be doing some things, teaching them about medication, also about their diet. So if we're trying to decrease their fluid overall, so in addition to just restricting the amount of fluid they have, what are some other things that can help manage their fluid status with their diet?
Low sodium.
Yeah, low sodium. That's really important because we know water follows the sodium. So if you eat, even if they don't have very much fluid, they're not drinking a whole lot. If they're still eating a lot of salt, all that water is going to stay with them. And they're probably going to feel more thirst too. So we want to have a low sodium diet because that's going to help them be able to excrete more of that fluid. They eat a lot of sodium, it's all going to hang on with them. We probably want to teach them about some, this term, reduce oxygen consumption. Sometimes these people, because of the backup in their lungs, they just don't breathe very well. They're not effective. They might not be able to do the stairs. And so we might say, hey, because if you do the stairs, you're going to be wiped out. You're not going to be able to go do the thing you want to do. Take the elevator, right? Take breaks when you go do these things. And they're like, okay, but I got to go home and I got to make dinner for the family and I've got to vacuum the floor and then I got to go do this. And you say, okay, that's great. But you're going to have to make a timeline or a schedule because you're not going to be able to do all of these things, which seems simple. You and I might be able to go do them right away. They don't have the capacity. They'd get too tired. They get too fatigued. They can't do all that. So we're going to teach them how to take breaks and how to be able to kind of decrease how much oxygen they're using so they can do all the things in life they want to do. We talked a little bit about cardiac transplantation. It's very strict criteria. There's not a lot of hearts that are available for people, meaning, you know, you have to be a donor. You have to choose to say, yes, I want to donate. And there's not a whole lot of them, people that donate overall in general. And then it has to be somebody that matches up with you. So they make sure, they being the transplantation organizations, they make sure that there's very strict criteria because they want to make sure anybody who gets a heart is somebody who's going to take care of it. So if there are things like if you smoke, you are immediately not on the list for getting a transplant because they're like, no, you already are putting your body more at risk of smoking. So we can't give you this heart. There's other, I think alcohol use is another one, different lifestyle things. One thing to know, if you have a solid organ transplant like a heart, you are on anti-rejection medication for the rest of your life because it's somebody else's organ inside of you. And they do match it, try to make sure that you're a close match as possible. But our bodies have a great immune system that like to identify invaders. And when they find invaders like bacteria or viruses, they attack them. So our bodies can't differentiate this organ that's going to help save our lives from a virus or bacteria. They just see invader. So people with organ transplants take anti-rejection medicine, helps decrease their immune system so they don't attack that organ. But what happens then to the rest of that immune system? It's weakened, yeah. So we know that our patients who have solid organ transplants, when they're on this anti-rejection med, are they going to be more likely or less likely to get infections or just generally get sick?
More likely.
Yeah, they're a lot more likely. We have to really protect them. We really want to make sure, you know, what are some things we really encourage to like preventative care for these guys?
Avoid crowding.
Yeah, vaccinations are a big one for our patients because we're like, listen, I get that the flu might normally have been nothing for you, but now we have suppressed your immune system and you have this heart that's doing great, but it's also making you more at risk. And if you get the flu now, that might be very detrimental to you. And the medication is lifelong. You stop taking your anti-rejection therapy. I'm not saying that the patient will reject that organ, but it's very likely they could. And if the body rejects that organ stops working, right? Especially if it's the heart, that's pretty important. We want that to keep working. We have another question. Okay, so we want to evaluate the patient as understanding complications of a heart transplant if the patient stated which of these. Oh, the nurse would evaluate the patient as understanding. See, these questions, you have to read them, even me, sometimes a couple times to say, what is it saying? So are we looking for the true or the false statements? We're looking for the true statements because it says we're evaluating the patient as understanding. The patient does understand. Again, it's select all that apply. If you can't select them, I'm sorry. Are we ready? All right, so lifelong anti-rejection medicine is required. Great job. Malignancies are a risk, and this one's a little tricky. So malignancies like cancer, our immune system is usually what identifies those little cancerous cells or things and says, ooh, invader, and they attack them. But when our immune system is suppressed, we're not able to identify those cancerous cells as easily or quickly, so they are higher risk of developing cancer. Rejection can occur at any time, even with taking anti-rejection medicine. Yeah. Yes, yeah. You know, I don't know specifically for heart. Usually with each organ that they are checking for, there's some lab work you can do that talks about inflammation and your immune system response. A lot of times they're also just looking at whatever the organ, the function is. So they might look at the heart function as well, but I don't know specifically. But good question. And then anti-rejection medicine has no side effects. Anti-rejection medication has a lot of side effects because it does reduce your immune system so much that there's a lot of side effects to that. Infection, we talked about that. Okay, we're going to do a concept map together. And I'd actually like us, I think is this. Okay, so what I'd like us to do is get together in groups. You can do tables or whatnot. This is not the group project. This is just for classwork. So if you want to be in a group, maybe by tables, how does that work? Yeah. So I'm giving you guys a concept map for each table. And I want you guys to work on doing a couple of Acute problem. I want you guys to do, I mean.
We're gonna just.
One per group. So I don't know if you're feeling about. You did one for. I didn't want those people. Because then that really. Oh, changing it up. Changing it up. All right, once you guys are kind of moved around a little bit, I'm gonna start going through the case study so we can know what we're doing. All right, you guys ready? So take notes because I can't have all the screen on here. So write down the things you think are important. Mr. Ray. Yeah. Yeah, so take notes. Mr. Reyes is 65. He was diagnosed with heart failure 3 months ago by his HCP. What's HCP? Healthcare provider. He received a referral to the dietitian and the heart failure clinic where he's being seen today. So today he's at the heart failure clinic. He is found to have dyspnea, weight gain of 4 pounds, and bilateral pitting ankle edema during data collection. What's another word for data collection? Assessment. Yeah, it's just a tricky word that I think sometimes like NCLEX tests try to trick you up on. Data collection is your assessment. He has trouble sleeping at night, lying down. What's that called? Orthopnea. Orthopnea is when you have trouble breathing, when you're laying down flat or kind of, you just can't handle that. Often sleeping in a reclining chair. He is 50 pounds overweight, inactive, drinks 2 beers a day, and he quit smoking 5 years ago with a 40-pack year history. That means that he used to smoke for 40 years before this. All right, there's one more page with this. He also has a 5-year history of hypertension, high cholesterol, and a family history of cardiac disease. He retired early from his job as an industrial mechanic due to his heart failure. He lives with his wife and has 2 children within an hour away. With a new heart failure diagnosis, he reports feeling overwhelmed with the many challenges to his lifestyle. The nurse asks what questions he has to develop a teaching plan. All right, so now taking these, like this information from Mr. Reyes, I want you guys to do at least 3, so pick 3 nursing diagnoses, and I'll put them, like here's, I think those are some examples. Put some of these nursing diagnoses and then put together underneath there, what would be our assessment data? What are our factors influencing? Like, does that make kind of sense? Try to put some of those pieces together specifically. I don't think it's like, so these are. Yeah, you could choose 1 or 2 of them, but like with a key problem, it might be anxiety volume, and then you can say, what are the first one? Yeah. We can do this. And then yeah, I have a bag because my dog. I looked on my kid. I'll bring it tomorrow. Yeah. This one? Yeah.
So. Yeah.
It's supposed to be.
Oh, left. You're wrong. You're right. You're right. Left. Yeah, you're right. You're right.
Mental state.
Okay, so we've done some of these before in class, right? Yeah, okay. We're gonna go through and do them together. We're gonna talk through and then I'll tell you the answers. I think. Did I print them? I hope I did. Oh, well, hopefully I'll know them, right? All right, so let's begin. So first thing, let's kind of just read through. I'm gonna read out loud. You can follow along. The nurse is caring for a 68-year-old male client who presents for a routine clinic appointment. So first thing, when I see a big question like this anywhere, I like to just skip down to the question itself and just look to see what the question's asking. And it says, which 4 findings are most concerning? That's going to help me as I'm reading through the question to know what am I looking for. All right, so day 1. At 10 o'clock, a 68-year-old male presents for a routine clinic appointment, reports tiring easily when out shopping or for walks. Has been staying home and reading and watching television, reports difficulty sleeping, awakens with shortness of breath in the middle of the night. Reports 8-pound weight gain over past 2 weeks since last appointment. States normal appetite. Denies chest pain and back pain. States he's anxious about his condition. No known allergies. Current medications. Enalapril, 20 milligrams twice a day PO. Hydrochlorothiazide, 25 milligrams twice a day PO. Digoxin, 0.125 milligrams once a day PO. Assessment as follows. Alert and oriented ×4. Appears slightly anxious. Heart rate regular at 102 and 4+ pitting pedal and peritibial edema. What's peritibial edema? Yeah, your tibia, right? So it's not only pedal or like edema on the feet, it's also going up to the tibial area here. So that's significant. Once it once it starts building up so much on the feet, it kind of backflows to the rest of the legs as well. Respiratory rate or RR is unlabored, crackles in the bases bilaterally, abdomen soft, non-tender, bowel sounds active, skin warm, dry, and intact. Frequent urination, small amounts of clear yellow urine. Vital signs. At 10 o'clock, 98.6, heart rate 102, respirations 22, blood pressure 170 over 100, pulse ox 93, weight 215. All right, so read through these findings and kind of in your head, think which ones you feel are the most concerning.
Don't click here.
Yeah, yeah, you can click there too. So choose yours. We're just gonna kind of go over it together as well. I'm just gonna pull up the answer sheet over here so I can make sure I'm telling you the right answer as well. Okay, so now hopefully everybody has their 4 top findings. Who had anxious? Okay. 4+ pitting and peritibial edema.
Yeah.
Nice job. That is one of the findings. Crackles and bilateral lung bases. Ooh, lots of you guys. So that also is one of the findings. Frequent urination. Not one of the findings. His appetite. Awakening at night with shortness of breath. Yeah, that lets us know his lungs are not doing so good. Weight gain. Yeah, and then heart rate, no. So even though some of these findings are concerning, right? Like his heart rate is a little elevated, I'd be concerned about some of these other things. They're not the most important. When we talk about patients with heart failure, we want them to monitor for weight gain. Like, and this tells us some about that. How much weight per day do we tell them to report if they've gained more than this much per day? 2 pounds. 2 pounds is the threshold. So what we tell them is weigh yourself every day, the same time every day, wearing about the same type of clothes, right? Because if they're wearing big heavy sweatsuit one day and then in their undies the next day, you know, that weight's not going to be the same. But weigh every day. And if you gain 2 pounds in one day, that's not you eating a big dinner, right? That's you retaining a lot of fluid. And that lets us know about your heart failure status. All right, so we chose 4+ pitting edema, crackles, getting up at night with shortness of air, and weight gain. Those are the ones that really are concerning. So as a class, you guys all got the right one. So number 2, and this is a test taking strategy I like to do because these case studies, you're going to see these in NCLEX, you're going to see stuff like this in my class, in my tests. There's all these words, but is it any different than what was in the last question? It's the same thing. So I would say, don't waste your time rereading it. If you can say, okay, it was day 1, 10 o'clock vital signs. I don't need to reread the whole thing unless I need to go back and get more information. So I'm just going to go down here. Drag the most appropriate words to fill in the blank. Oh, do these questions sound kind of familiar? Mm-hmm. We've seen these on our tests, right? Okay, so the 2 problems that he's is at most risk for developing. So at most risk means he doesn't necessarily have this condition, but he's at highest risk of developing it. So read through these conditions down here and tell me which problems he's most at risk for. Whew, words. All right, so somebody from this side of the room, what's one of the problems we're most at risk for? I think everybody kind of just said it at once. Yeah, fluid volume overload, right? That one's kind of like, yeah, that's, if I was looking through this list, that's probably one I would pick out at first saying, yeah, he's at risk for having too much fluid volume. So I'm going to pull that one over. And the second one, so from this side of the room, what's the second one? So I hear heart attack. I hear electrolyte imbalance too. Electrolyte imbalance. That's the other one. Why is it electrolyte imbalance? Yeah. Right. He's got excess of fluid, so he might be diluted with a lot of things, and we're giving him a lot of medications that are going to change his electrolyte balance by either pulling potassium, sodium. Can you say that one more time?
Stay in the body instead of leaving the body.
Going in the potty. Yeah, and so toxins being like all those extra electrolytes are things that we don't need. Yeah, that's good. All right, so I'm gonna pull electrolyte imbalance over here. Okay, all right. So now looking over the question, we have some new information. So let's look over the new information. And what we have is lab results. Cholesterol 248, BUN 10, creatinine 1.5, hematocrit 34.6, hemoglobin 13.5, potassium 2.8, sodium 135, chloride 95. So which abnormal lab findings should the nurse address first? Don't answer out loud. Don't answer out loud. Look through them all. Okay, somebody who hasn't answered yet. Mickey, good job.
Potassium.
Potassium, yeah. So why is the potassium most concerning out of all of these? Yeah, we know there's a direct correlation with potassium imbalances and cardiac dysrhythmias. All right, potassium. All right, next. Okay, do we have more information? No, we don't. It's still the same notes, the same vital signs, the same lab results. So we don't have to reread everything. What should the nurse include in the teaching plan? Select all that apply. So you guys can read over that yourselves.
Oh, no.
Yeah.
Okay, we read through them?
Yeah.
All right, do we think weigh yourself at the same time every day in the same clothes? Raise your hand if that one is correct.
Yes.
Yeah, I just said, I didn't realize I just gave you guys the answer. Good job. Do we increase our oral fluids to stay hydrated?
No.
No. What are we probably gonna do? We're probably gonna restrict the fluids. Do we limit our sodium in the diet to no more than 2 grams a day?
Yes.
Yes, yeah, we do, right? Water, fluid is gonna follow the sodium. The more sodium they have, the more fluid they're gonna have. Immediately report 1 pound of weight gain in 1 day or 3 pounds in 1 week. No, right? Yeah, 2 pounds per day. It doesn't say on here, but the rule of thumb is generally 5 pounds in 1 week. So 2 pounds per day or 5 pounds in 1 week, right? That lets us know, because generally people don't gain 5 pounds a week. I mean, if you just went off on a cookie bender, maybe, but with heart failure, we're really wanting to monitor that like weight status because it's most likely fluid. Okay, limit exercise and physical activity. I know that's like the most opposite to patient teaching stuff, right? Take the prescribed medicine every day, even if you're feeling better.
Yes.
Yeah. Eat foods high in potassium. Yeah, why do we eat foods high in potassium? Yes, exactly. Did you guys hear? Say a little louder. to offset the imbalance, right? A lot of these, some of the medication that he's taking is going to be potassium wasting. It's going to get rid of some of the potassium. And so we want to eat foods high in potassium so that we can keep our potassium level balanced. He is on a diuretic. Yeah, he's. Say again?
On a diuretic, that's the diuretic.
There's certain medications that will waste potassium, and there's certain medications that will spare or keep potassium. And he is on,
I know.
yeah, hydrochlorothiazide that will waste some potassium. All right. Are you good, Mr. Eric? Just stretching. Okay, what did I say?
Good for you, try to do something.
Okay, fifth question. Do we have more information to read? No. Okay. So which following action should the nurse take in response to the change in medical orders? Oh, we do have new information. Okay. So there's our 10 o'clock note, and then we have a 10:30. Order to discontinue digoxin and begin sacubitril valsartan, 4951 milligrams. You guys know what that means when they do those slashes? So what that means, where's the little pointy guy? It means there's two medications, sacubitril and valsartan, and then 4951. Those are the doses. So it's 49 of sacubitril and it's milligrams, and 51 milligrams of valsartan. So sometimes you will see medications, especially the combination medications, written like that, where they have the slash between the names and the milligrams.
So that's a combination.
It's a combination drug. So he said to discontinue digoxin, begin sacubitril and valsartan, along with a nutrition dietitian consult. Begin a low sodium diet and fluid restriction, 1,500 milliliters every 24 hours. Instructed to weigh himself daily and record. Return to the clinic in 3 weeks for follow-up. All right, so select all that apply, what responses we should take to these orders. All right, you guys ready to go over? All right, raise your hand if you think question medical order. Ooh, brave, Eric. Why are we questioning the medical order? You generally, there is, so it is correct. We do want to question this order. I want you guys to reread some of this information, and I want you to tell me, why are we questioning this order? It's not about stopping the digoxin suddenly.
Is it about the new medication?
Is,
Yes. Yeah. So Myrna, say it a little bit louder.
The enalapril and the sacubitril are the same type of medication?
Yeah. Yeah. So he's essentially ordering the same medication for the patient. And the clue is, when we talk about medications in a little bit, he's already on, where is it at? Oh, I'm sorry, I can't find it.
Right there.
Enalapril. He's already on enalapril. And the pril is a clue. Oh,
right.
yeah. ACE inhibitors had that pril. And then we see here, sacubitril.
Yeah.
What is it, valsartan?
Well, let's start with PRP.
Yeah, thank you. Yeah. So essentially, he's doubling up this medication class. The patient's already on that medication. And so we need to say, hey, do you want this? Because they're already on this medication. Doesn't mean they can't be, but we want to confirm that the doctor didn't mean to discontinue both of those meds and then start this one as well. Eric, you said we do need to educate them about stopping the digoxin, right? We probably don't want to, like, and you can, depending on their dose. It's not one that we just say don't stop cold turkey, but we want to have them monitor for their signs and symptoms of heart failure too. Okay, instruct the client to start the new medication today. We're gonna wait until we hear from the provider, because we are not sure about this yet, and until we know what the provider, if they're for sure want this medication, we're not gonna tell them to take that medicine yet. Tell client to take an additional dose of the diuretic today. No, there's no reason I see on here we should do that. Request that the provider order potassium supplements.
Yeah.
Yeah, we know this guy's probably gonna have some potassium depletion, so we need to get some extra potassium. Ask the dietitian to meet with the client. Yes. And then determine if the client owns a scale. Yeah, so important. I feel like so many times we get in these boxes, we're like, tell them to weigh every day, report 2 pounds in one day, 5 pounds in a week. Okay, go. And then the patient goes home and they're like, well, I don't have a scale, so I don't know how I'm gonna report any of this. So our first step in doing this is to say, do you have a scale? Do you have a way of weighing yourself? All right, moving on. Okay, last question for this one. All right, so we do have day 14 notes, so we can read that a little. It says clients called the clinic to report a nagging cough, pink tinged sputum, and difficulty catching his breath. States he's sleeping in a recliner because he can't breathe when he's laying down in bed. Notes his wife checked his pulse and it's 90. Report lack of appetite, thirst, and getting up twice per night to urinate. States he is worried about his health. Advise client that worsening symptoms need immediate attention. Spoke with client's wife, who agreed to take him to the emergency room. Ooh, what's probably going on with him? Yeah, he's probably got some acute on chronic heart failure. We know he has chronic heart failure, but it sounds like there's some acute issues happening too. All right, so in this type of question, you're looking at each of these issues, sleeping in the recliner. Is that improved from where he was? Is that worsened, or is that unchanged? So kind of look through these. Let me make sure I tell you guys the right, because. All right, so sleeping in the recliner, how is that? Is that unchanged?
Yes.
Was he?
Yeah.
Yes.
That,
That was the concept map.
I think that was the concept map.
Yeah. I didn't see it here.
I don't see anywhere where it says he's actually laying down in this one. So I would say it's probably worsened. Yeah. The nagging cough. Worsened. Yeah, I don't see a cough up there. Pink tinged sputum. That's worsened. We know that one. Pulse. Yeah, because it was 102 and then the wife says it's 90 now. So yeah, that's improved. Lack of appetite. Yeah, worsened. What? Yeah, worsened because up here he said states normal appetite. And then on day 14, he says, oh gosh, where is it? Lack of appetite. Thank you. Getting up at night to urinate. Yeah, so it says worsened. It's in the first part, it does say he's frequently urinating, but it doesn't say anything about at nighttime. So since we don't have anything to go, we don't have that information. If we know he's for sure doing it at night right now, we're gonna say worsened. All right, last one is thirst. Let's see, where does it talk about thirst in the top? Normal appetite.
I don't think it mentions thirst.
I don't think so. And then where does it say here? Reports lack of appetite and thirst. I think it's unchanged.
But that's a different day, isn't it?
Yeah.
What he's reporting that's happening now. So in 2 weeks, he's lost his appetite, now he's thirsty. Oh, I guess.
Well, the University of Maryland says that it's unchanged.
Okay,
Yeah.
You missed the pink tinge,
yeah.
you know?
Oh, no.
Yeah.
Okay, that one is for sure. Okay. And then based on this concept map, I want you guys to go back. Sorry, do your thing. Oh, you want me to go back?
Get to the paragraph or go down. to the
So thirst is
thing,
unchanged.
so I can see.
It said it was unchanged for them. And their reasoning that they give is. Oh, they said thirst is unrelated to heart failure, and that's why it's unchanged. I don't know if I love that part of the question. Yeah. Okay, so now let's go over and I want to do the bow tie question as well. And again, there's a link for that one in the week 9 resources. I think so. Yes. Okay. So now this one's not part of a case study, but I really like these bow tie questions. I think they kind of help us think. So it says the nurse is caring for a 68-year-old client who's admitted to the medical unit from an outpatient clinic. So down here, I can see, okay, it's a bow tie. What are they most likely experiencing? What are 2 actions I'm going to take? And what are 2 parameters to monitor? So day 1, 11 o'clock, client reports his primary provider sent him to the hospital after his follow-up appointment today because of a nagging cough, pink tinged sputum, and difficulty catching his breath. States he's sleeping in a recliner because of difficulty breathing when laying down in bed. Reports lack of appetite, thirst, and getting up twice per night to urinate. States feeling worried about health, no known drug allergies. So just a quick note, because I think, Dwayne, you asked if this was the same patient. It looks to me like it is, but I just want to note in my test or in NCLEX, if it's not part of that case study, I would not say this is the exact same patient. I would only go off of the information in this question. Because maybe something's asking you a question and you're like, oh, but I know he was on these certain medications from the other questions. But if it's not stated in this question that's separate from the case study, you just want to go off of this question's information. All right, so history and physical. Cardiac regular rhythm, tachycardia, 4+ pitting and peritibial edema. Respiratory is unlabeled, crackles in the bases bilaterally. Neuro, oriented to time, person, place, situation, and anxious. GI, abdomen soft and non-tender and the bowel sounds are active. Skin is warm, dry, and intact. GU, frequent urination, small amounts of clear yellow, no foul odor. Temperature, 98.6, pulse, 110, respirations, 22, pressures, 170/110, pulse ox, 93, weight, 215. Okay, from the choices, what is one condition we think they're probably experiencing? Yeah, I totally agree. We've got these signs and symptoms that are very like the swelling, the respiratory issues, pink frothy sputum, the weight gain, the blood pressure and heart rate that are up. Those are all clues. So where are we at? Heart failure. All right, so now 2 actions that we're going to take. So read through. I hear a lot. I hear a lot of diuretics and fluid restriction. Anybody have any other guesses? Yeah, I think that's pretty much it. Fluid restriction and diuretic. We don't want to put a Foley catheter in. Why? Yeah, we know there's a big risk of infection with those. Administer IV antibiotic. I don't think he has an infection. And then give him normal saline. What would that do? Good Lord, that would just make him drown. We don't want to do that. Okay, so 2 people who haven't answered yet. 2 parameters that we should monitor. Two people, so raise your hand if you haven't answered yet. Wayne. Yes, absolutely. And then somebody else, what's the other parameter we were gonna monitor? Hold on. Yes, lung sounds. For a minute, I was thinking it might be pulse ox, but it's really, the lung sounds are gonna be more indicative to us of how that fluid is doing. All right, nice job, you guys. You successfully completed the bow tie. Woo! All right, and now I'm going to go back to a mentee where we talk about heart failure. No, hypertension. We already talked about heart failure. Sorry, I get them, sometimes I'll say the wrong words because I think hypertension and heart failure are so intertwined. They're so like dependent on each other. Done with that one. Now we're gonna talk about hypertension. Excuse me. Oh, shoot. Hold on.
Turner wants to know what's up with your pistachio.
Pistat, oh, I don't even know. How does that happen? I don't even like pistachios. I mean, I'm not against them. I just wouldn't choose them over most nuts, I guess.
All right, can somebody tell me what that number is?
8-4-3-8.
8-4-3-8.
4319.
4319. You know what the trick to this dyslexic is? If you ever have trouble with numbers, group them up into pairs of 2.
I can say 8349 really well, but if I try to just do those numbers, most of the time I'm gonna flip those babies around.
You said 83-40.
Oh, did I already do it? Yeah, yeah. When I used to have to do dosage calculations for, back in the day before we had pumps that would calculate medications for you, and I had to actually calculate drip factor and how much this patient would get, and it was these critical medications. Guys, I freaked out. I used to have everybody and their mom check my math because I know that I am not great at, I put numbers around, I'm dyslexic. And so I got really concerned. Let's see. Thank you.
Any shape?
Do you mind having me?
They want an extra one for.
Oh, no. Why is this happening? Okay, I need to get some scissors. So if you need extra balloons, here's one if you don't get one. You guys need balloons? Oh, no. I'm sorry. I'll be right back.
I'll be the kid. I-type mo na lang sa pad. Diyan sa ako na sa
Oh my God.
Yeah.
There was that recommendation. You have to watch a video.
Why you think that?
Yeah. Experts can help us. He's away. Well, some hours. You know, when you put border, you just need to do the whole like 10 hours. When was that? They're gonna ask for that. Oh, no, you know what? Hindi na ako
These guys off.
I got 25. And then people use the feet and I.
What's that?
Oh, no, sorry.
If I have snap.
No, because she told me. Oh, yeah, I have like. Oh, yeah. It's a bit. That's all right. Something like that. But I did
Big balloons?
Yeah.
Raise your hand if you need a big or a little balloon. A big balloon? You have one? Okay. Okay, it is so hard to find water balloons this time of year. What's that? All they had were these like funny, like you put them in, like people are so lazy, they don't blow up their own water balloons anymore, I guess. You just do these. I thought it was so funny. I mean, that's true. Okay, so we're gonna be talking about hypertension. Hypertension is high pressure. When we talk about hypertension, I want to go back and think about blood flow through the heart, but then it goes through the rest of our system, right? Goes through all of our blood vessels, into the capillaries, and then back into our, actually, I guess we'd say first the arteries, right? We're going to arteries away from the heart, into the capillaries, and then into our veins to come back to the heart. And a lot of times, especially because of heart failure or some other issues, we can have hypertension where the pressure that's in those blood vessels is too high. There's a lot of things that can make that pressure too high. And that's why we have the balloons to kind of do a little example. So take your big balloon, okay? We're gonna say this is like a regular old person. So go ahead and blow up your balloon. Oh, that's color, yeah. So did you feel that pressure that you had to start going to blow up the balloon?
Yes.
That's the afterload, right? That's the amount of pressure you have to overcome to push things out of the heart, right? That's an example of afterload.
Oh.
And that blew up pretty good for most everybody, right? Okay, so we let them go. Pick up your little balloon. When we have, this is so pretty. I know. Okay, so get your little balloon. Okay.
Jeez.
What?
What?
Yeah. So pick up the little balloon, just look at it for a minute. It's probably gonna be easier or harder to blow up?
Harder.
Harder, a lot harder. So try to blow it up.
It's hard.
You're right. I give up. I'm not doing so good. Oh, that's pretty good. Nice. So what are some factors that make it harder to blow up the littler balloon versus the big balloon? The tubes? I heard, what did you say? You're not very used lungs as well. Somebody, why is it harder to use to blow this one up?
It's not that bad.
There's no resistance. I heard, Rena say there's constriction here. I would say there's less compliance, right? Like our blood vessels might kind of expand, like our bigger balloon expanded. This one does not want to expand like it normally is, constricted, right?
Yeah.
So when we have some issues, stenosis, other areas causing more feedback, you can see how that dam can start backing up and start causing more even resistance there. Okay, we're gonna come back to our balloons as we go through today. All right, everybody in the Minty, give me a thumbs up. Happy if we're here. So the pressure, when we're measuring our blood pressure, that's actually the pressure of our blood vessels, right? We're not measuring pressure of like how fast something's coming out of our heart or anything like that. We're just saying, what is the pressure that's pushed on our blood vessels? Now it's determined by a lot. How does blood volume determine the blood pressure? I hear words, I just can't understand them. I'm so, one second, I don't even know who's talking right now, because I just hear like everybody's mouth the same and somebody raise their hand if they're willing to share. Okay, yes, go ahead, Jay. Louder, sorry.
It's like super blood. I think there's like a lot of.
Blood volume, how does blood volume? Or there's more volume, right? So if we have a lot of volume in our lungs, where my little balloons go? If my lungs are real big, like I'm knee size, I could probably blow this up a lot. I have a lot of volume. Is a little baby, like a toddler, their lung volume is very small with how much they can push out. Can they make this balloon go as much? No. So if you have a lower volume in general, it's going to be less pressure than overall. What about blood viscosity?
It's harder.
It gets kind of thicker, yeah, if we're pretty dehydrated, or if we have a lot of toxins in our blood, that can make it thicker to kind of go through. Vessel stretch. Weak or normally what we see with our blood vessels is they get sclerosed or hardened. So that's a good example of like this balloon is really stretchy, right? It can move all over the place. If I take this little balloon, especially this up part here, this does not want to stretch very much. And this little blood vessel or whatever you want to call it, it is not stretchy at all. There's not much air that can go through here. So when our blood vessels get sclerosed or hardened and scarred, they don't stretch and allow more fluid to go through.
That's like.
Was that in the bag?
Yeah.
Oh, yeah. A lot harder. Yeah, got you. So stenosis is when you have like scarring and hardening of the vessels. Sclerosis is when you have plaque buildup. And so that can make it usually more narrow, right? So stenosis, it's not gonna, it's like it's stuck. Stenosis is stuck, it won't stretch. Sclerosis is where you might have the blood vessel here. Here's the blood vessel, that's not a good one. And then you have these plaques that build up. And it's not that it won't stretch, but it just, there's less volume that can go through because now it's a smaller area to go through. Yeah. It won't turn into it because you're still gonna have the plaques, but you could have sclerosis and stenosis at the same time. You could have somebody who has plaque buildup in their blood vessels, and they could also have scarring, which allows those blood vessels not to expand and stretch as much. Which of the fluid is the stent in? I mean, it could be both. It depends on, are they having restricted flow because it's really closed up, because it's not stretching, and then you just stretch it open? Or is there plaque there? Then sometimes they kind of endarterectomies, that's kind of where they clean up all that plaque too. Peripheral vascular resistance. How would that affect the blood pressure? Right? So resistance, so constriction. If all of our blood vessels were like little tiny balloons like Amy had, right? That's a lot of resistance. What's gonna go to the, what will happen to the pressure?
Right.
That'll go higher. If all of our blood vessels are like these bigger balloons and they'll stretch and get bigger and open up, what will happen to our pressure? Yeah, it'll lower. All right, so when we talk about blood pressures, you guys know, because I know you learned how to do two-step blood pressures way back when and all these things. We know that the systolic, so systolic, let's go for just a sec. Well, I don't know, I'll go over a minute. Normal is a systolic of less than 120 and diastolic less than 80. We can say somebody is a little bit elevated when it's 120, 129, or just under 130. So when we kind of keep 180 actually, because we start saying that stage 1 hypertension, and I'm not going to ask you about which stage they're in. I'm going to give you guys numbers and you'll have to infer, is it a high blood pressure? Is it a low blood pressure? Those be part of like the patient. When they start getting 130s to 139 and then above 140s, and then eventually above 180, above 190, that's hypertension. These numbers actually keep getting lower and lower. Years ago, it used to be if it was over 150, that's when they would consider high blood pressure. And now we've discovered that the higher your blood pressure is, even just little bits up to 130, 40, that's where you start having damages. Yeah.
Those mics that are over 140, say, oh Lord.
Oh Lord.
My boy right now.
I know. We need to have him like come be a guest speaker for some of this.
Oh, that's pain.
So when we talk about hypertension, there's two types. There's primary and secondary. And so let's talk about secondary because I think that kind of makes more sense. Let's say somebody has kidney failure. They can't excrete urine and other toxins like they normally would. What's that going to do for overall blood volume?
Right.
It's going to increase it. What's going to happen to our blood pressure? It's going to go high. A lot of patients with renal failure have hypertension because they have an increased blood flow. They have too much, what's the word? Fluid volume, right? They have too much fluid volume. It causes them to have hypertension.
It's kind of what I would think, is that hypertension caused by the renal failure or renal failure caused hypertension?
They both can be true. The scenario I just gave you was that somebody has renal failure and they can develop hypertension from that fluid volume overload. But you could have somebody that doesn't have renal failure, and then for whatever reason, they have high blood pressure. That high pressure over time can cause damage to other main organs like the kidneys. And because of that high blood pressure, they can actually develop kidney failure. So what I'm going over here, it's primary and secondary. A lot of times when people have high blood pressure, we don't know the cause, and we call that primary. It's a lot of times it's a hereditary thing. Blood pressure runs in your family, you just tend to have high blood pressure. It's not from another disease or something else that's causing it. If there's another disease causing it, a lot of times we can correct the blood pressure if we can correct the disease. People who have chronic renal failure, we can't really correct chronic renal failure, right? So we just know, hey, we're gonna try to manage it the best we can, and we're gonna manage the high blood pressure. A lot of times they call hypertension the silent killer, because there's not a lot of signs and symptoms of high blood pressure until it gets crazy elevated way late in the game. Sometimes if people have a high blood pressure, they can have headache, bloody nose. Why would they have a bloody nose? It's the pressure. All those tiny little balloons, vessels in their nose are popping and they're bleeding because there's so much pressure. But usually people don't have signs and symptoms of high blood pressure. And that's why it can cause damage to those internal organs, because people are living thinking they're doing just fine. And then all the while that high pressure is causing damage to some of the organs like the kidney. And then when they're diagnosed with high blood pressure, they already have some issues with other organs. So that's why we do so much work with screening and looking at people and saying, are you a risk for high blood pressure? Identifying people when their pressure just starts to go up so we can control it before it becomes a problem. We talk about a couple different types of modifiers because we know that lifestyle can make a big change on hypertension. So tell me, friends, the nurse is including which of these as modifiable risk factors? Select all that apply, or just if you can only choose one, choose one. Age, diet, family history, glucose control, or weight control? Oh, wait, I didn't say yes. Ha, sorry. Okay, so yes, everybody got diet. That's a pretty good one. What's one of the biggest things we say for diet with high blood pressure? The DASH diet or low sodium. We want to really like this water fluid will follow the sodium. So if you can decrease that sodium, that's going to help with the overall pressure. Family history, I can't control glucose though. I can't control that, right? There are things by eating certain things, taking my medicine regularly, diabetic, I can help control that glucose number. Weight control, I also can help control that number too. These ones are definitely, I think, a little more difficult conceptually, but we can control those. You can't modify that family history, your age, right? The older you get, we know that the more your blood vessels don't have as much stretch as they normally would when you're younger. We can't modify that or change that. There's also certain race and ethnicities that are more likely to have high blood pressure. And that's not anything that you can change. That's just part of people's history. I just asked the same question. I'm skipping this. Sorry. So modifiable risk factors, weight control, limit sodium. Like we talked about earlier, let's try to increase some of that potassium, increase our physical activity, and glucose control. Dun, dun, dun. So the nurse evaluates the patient as understanding nutritional teaching to manage hypertension if the patient made which of the following statements. Select all that apply. All right, so yes, we're gonna follow that DASH dietary pattern. And do you guys read about the DASH in your books? So go to your books. They have a nice little paragraph about the DASH diet that was developed, gosh, I want to say 30 years ago, maybe longer, and really talking about how do we help people control their high blood pressure through their diet. And there's some great principles in there with reducing sodium, reducing some of like the boxed foods you eat, eating more fresh and natural things that have higher fiber in them. A lot of good principles. I would look over that chapter in the book. I will limit my alcohol intake for sure. Alcohol use can cause, it's one of those things that like if you have almost any disease, it's like smoking and alcohol are gonna make everything worse. And then limit our fluid intake. This one gets tricky because we just talked about heart failure. But if this patient, we don't know anything about heart failure with them, if we just know they have high blood pressure, do we need to limit the fluid intake? No, we don't actually. We probably want to have them maintain a good, like at least 2 liters of water a day, because that's going to help flush their system, get rid of any excess toxins. Really the focus is going to be kind of like with diabetes. It's like lifestyle modification is going to be our first thing. We're going to also, when patients start to come into a clinic, you always start with lifestyle modifications. I say always, I hate always and never statements. You know, if somebody's blood pressure is like 250 and they're hospitalized and you just can't get it down to something, they're probably going to need to be on a hypertensive, antihypertensive. Most of the time, the average person that comes in with elevated blood pressure, they start with medical management. Dietary lifestyle management, sorry. Because a lot of times you can increase your activity, you could change your diet, you can lower your blood pressure. There's also things psychosomatically that can lower blood pressure. What am I talking about? Anybody know?
With less stress.
Less decreasing your stress, meditation. People talk about stretching, yoga, things that can kind of help calm our mind. Our mind and our body are so connected that when we have extra stress and bad juju, whatever, it can actually cause our blood pressure to go up. One thing I do want to make note of is that we always want to make sure we check people's blood pressure. We have 2 consecutive readings of high blood pressure. Anybody know what white coat syndrome is? Yeah.
They come in and they get like they're nervous.
Yeah, they're scared about going to the doctor's office. And so anytime they see that white coat, they get nervous and their blood pressure goes up. And then we have these people who they would be put on blood pressure medicine and they'd go home and they'd pass out. Their blood pressure was too low. But they didn't have high blood pressure. They had nervousness around doctors or people with white coats. So we always want to say 2 consecutive readings. A lot of times I used to do blood pressure screenings like at farmers markets and places like that. If somebody's blood pressure was a little bit high, a lot of times I'd say, hey, you know, almost every drugstore or Target or Walmart or wherever has like those little blood pressure machines. I tell them, you know, every time you go in there, at least once a week or so, check, see what your blood pressure is. That's just a normal thing. You know, you're out shopping, you're living life. You're not like nervous around a provider or a doctor. See what it is. If it's higher, then you probably do need to get followed up. We're gonna talk more about these medications in just a little bit. So what does the nurse include in the patient teaching plan for the patient to prevent falls when taking antihypertensive medicines? So we're given some antihypertensive medicine to somebody probably new with it. And how do we prevent falls if somebody who's getting antihypertensive medicines? Nope, stand up quickly should not be correct. Good job for not choosing that one. So sit at the bedside when changing positions, right? We don't want people because we know orthostatic hypotension, right? You guys learned how to do like a 3-step blood pressure series. So lying, sitting, and then standing. We want to make sure that people can compensate for this lower blood pressure we're letting them have with the antihypertensives. So we want them to just sit at first, and then stand up. And then the next one is rise slowly when they're standing. You know, somebody, especially when they're new, getting blood pressure medicine, we don't want them to just pop up because they might, all of a sudden, their pressure might not be able to compensate so quickly. So you want to be slow. And then if you feel dizzy, sit down. That seems common sense, but sometimes people might think, oh, I guess dizziness is just part of my life now, you know, it's like, no, it's not. Don't stand up quickly, and then get help to stand if you have a history of falls. So our patients, if we know they're already fallen down on their own without having new medicine on place, we're gonna say, hey, get some help. Have somebody help you, especially until we know how this medicine affects you. The nurse evaluates the patient as understanding hypertensive therapy teaching if the patient states hypertension must be managed for which time frame? How long do people have to manage their hypertension?
What's option 4?
Oh, option 4 is the correct answer.
Yeah, what is that? What does it say?
I'm gonna go with option 4.
I'm going to go with option.
Option 4 was supposed to be lifetime.
Oh.
I don't know how that didn't say. Oh, okay. So what the question is getting at is, can you cure somebody from having hypertension? No.
Unless it's
Yeah.
secondary.
Unless it's secondary and we can correct that initial issue, right? Hypertension is lifelong. That's kind of like we talked about diabetes. It's a lifelong disease that you always have to manage. Same thing with hypertension. Even if they start feeling better, they're doing, you know, we still want them to keep managing it. There's some people who can manage their hypertension with lifestyle and diet choices. Does that mean that if they become sedentary and start eating a not healthy diet, that they don't have hypertension anymore? No, we're probably going to see their blood pressure go up if they don't follow those lifestyle managements anymore. Oh, boom. So complications. Talked about why is it so important to manage hypertension? And when I say it's the silent killer, because look at all of these things that can be complicated. You can have atherosclerosis, which I was talking about over here, where the blood vessels get really hardened. They don't stretch as much. Coronary artery disease, eye damage in general, kind of damages those blood vessels, can lead to blindness. It can damage your kidneys. It can eventually lead to kidney failure. It can lead to heart failure, myocardial infarction, or stroke. So there's a lot of big things that can happen with hypertension. A lot of people think it's not a big deal. I feel fine. But after a while, because a lot of people live with hypertension for decades without treating it. And then all of a sudden it's like, wow, now your body it's coping for a while, because you can cope with things for a while, but then it will catch up and your body just can't handle it. There is something called hypertensive urgency, and so it says, the book calls it severe blood pressure elevation without target organ dysfunction progression. It's such a mouthful. What it really means is, so there's hypertensive urgency and then hypertension emergency. So hypertensive urgency is where you have a severely elevated blood pressure. A lot of times it's over 180, but you're not at risk of damaging vital organs, heart, brain, liver, you know, we're not worried quite about that yet. So it's kind of like, we're worried about it, but you're not damaging anything yet. We want to treat this though. Hypertensive emergency, and again, usually 180 or higher, over 120 or higher. And that's where we think, gosh, this is getting to the point where we're worried there might be damage to some of these organs happening right now. Not from long-term high blood pressure, but this pressure is so high, this might be actively right now hurting some of these organs. So what do we do for this?
So this IV nitro.
Yeah, so IV nitroprusside, we want to get the blood pressure down, right? That's the biggest thing. We're like, okay, their blood pressure is so high, we want to get this blood pressure down. Here's the trick though. Do we want to get this blood pressure? Do we want to go from 180 all the way down to like 110? No, we actually don't. And we're going to follow our provider's orders. They're going to give us a range to say, you know, give medicines, keep the blood pressure within a certain range, because let's say this person, they've been living this way for a while. Their pressure is normally 170, 180. Their body is compensated for that. If we suddenly drop that pressure, all those vital organs are not going to be getting the same oxygen that they would until our body kind of adjusts. So you want to, when it's that high, you want to get it down lower. Usually I'll see they want to get it down to like the 160s for a while, and then they keep kind of gradually getting it down over the next couple days. They don't want to drop it too quickly because you could cause damage to the organs from the other way of not having enough pressure when they've built up having so much pressure for a while. Which of these nursing diagnoses is appropriate for a patient with new onset hypertension who's requested information to manage the hypertension? So when we're looking at nursing diagnoses, new onset hypertension, and they want information about how to manage it. Yeah, so readiness for enhanced health literacy. This was a Davis question I put in just because I feel like it's good to kind of look at them. I think this is one of those questions we can kind of find the right answer just by eliminating the incorrect ones. So when we say increased cardiac output, do we know he has increased cardiac output? We don't, nothing other than just saying he has hypertension tells us that, so that wouldn't be correct. Ineffective health management. He's actually saying he's asking for information. So I don't know that he's managing it incorrectly. If anything, it might be he's trying. Ineffective coping. I don't really know anything about that from this question, but he's asking for information. So readiness for enhanced health literacy. That's kind of a mouthful of a nursing diagnosis. So that makes me think, hey, he's ready to start learning and learn more about his disease. So some of the other nursing diagnoses: ineffective health self-management, can't take care of himself as well, or he's not taking care of him or herself as well as they should. Risk for unstable blood pressure. So big thing that lifelong management, you just have to. They're going to usually be on medications. Most people start with a diuretic, try to lower that volume overall, get that pressure down. And then as their disease progresses, or if that's just not effective enough, then they're going to add some other medication. One thing we always say, just like we talked earlier, even if you're feeling good, keep taking your medication. But we also want to talk to them about side effects, right? So some of the biggest side effects for men especially is erectile dysfunction. And that can be a big barrier to men taking their medication. If they're like, well, no, this is one of the side effects. I'm not okay with that. I don't want to take this medicine. And so that's a good starting point of saying, hey, all right, thank you for telling me. Let's see what other options do we have that might not have the same effect for them, because we want them to take their medication. If there's a barrier and they're telling us they're not going to, then what do we need to do differently about it? There's a lot of different side effects to the medication, which what were we talking about earlier? But just in general, if we can get the patients to buy in on what we're telling them to do, like if we're saying decrease less fluid for the heart failure patients, if we just say don't drink the fluid, they're going to get angry and mad. But if we can explain to them what this is why we're doing it, and if you drink more, this is how you're going to feel, they're more likely to be compliant. Patient safety, especially when beginning the antihypertensives, because that pressure is going low, we're keeping it lower, they're at higher risk of getting dizzy or just having a little bit of a lower pressure. And so we're teaching them this is how you monitor for a low pressure. We also want to teach them about hydration balance, because a lot of these guys are going to be on the diuretics, going to make them pee a lot, get rid of a lot of that fluid. And so we want to teach them, because of that, you need to make sure you're drinking enough water as well. I know a lot of little old ladies that they're like, I pee all the time with this medicine, so I just don't drink water. Well, that's not healthy, right? Then they're dehydrated and have low volume. So we just need to do some education with them. Okay, cue recognition. We're taking care of Miss King. She's a resident. Let's say we're at a long-term care. She's 84. She gets up from a chair in the activity room to go to the dining room, and she says, "Oh my, I feel dizzy," and then slumps back into the chair really quickly. Miss King takes antihypertensive medicine. Turn to your neighbor and just talk about what would you do, and think about what you would do right now, but then also planning maybe for taking care of her later in the day, later in the week.
would be like, static tension, pressure, and then I'm gonna introduce you to that right away.
Yeah.
And I think in class also, yeah. What is it? No, you need to, there's a deadline.
Okay, let's come back together and see, what did Davis say? All right, so the first thing, let's ensure some safety, right? Let's go check on her, see how we're doing. Probably gonna get vital signs, right? See what other balances she has. And then we're gonna teach her, what are we gonna teach her about standing up or moving? Slow, take your time. And then we wanna talk to the doc, let them know that she's having this issue, right? We kind of talked about that. I don't really care so much about the cuss. And I don't care so much about this. So, so some of these things I leave in the PowerPoint specifically because I think they can be helpful. So when you're studying for tests and different things, I think it's always great to go through, usually at the end of most of the PowerPoints, they have like a concept map or activity queue. Those are great ways to check your knowledge. So I'm going to leave that up there. But we are done with the hypertension lecture. How about we take, guys want like till 10:45? And then we'll come back and we're going to do a medication activity.
Got an answer.
Oh, you did? Let me stop the recording so it doesn't get on the video. No, you're fine. Okay, so I remembered to put 12 medications on because we're gonna do our dice activity again today. Remember the dice activity where we didn't have dice, you had to pretend you were rolling? It's not as fun, but I brought dice today, guys, so we can do it. All right, so let's talk a little bit about some of the medications. So, you know, how I said earlier, usually with hypertension, they'll start people on a diuretic, usually. Hydrochlorothiazide is a pretty common one that they start on. So class thiazide diuretic. So what does it do? And that's what I'm just going to go. I'm going to go through, we're going to talk about different classes, what they do, and then what do you really need to know about it? So they increase the urine output because they help promote excretion of sodium, chloride, and remember, water follows the sodium, right? So if you excrete the sodium, same thing, water is going to follow after it. Hydrochlorothiazide is a really common thiazide diuretic, and see the HCTZ. That's because hydrochlorothiazide is kind of a tongue twister to say. So oftentimes you'll hear people say HCTZ, or a lot of times it's abbreviated to HCTZ. So a lot of times this is a potassium wasting diuretic. And so we want to monitor their potassium levels. And then we also know that this can kind of increase their blood sugar. So if they're diabetic, we're going to keep an eye on it. Loop diuretics, and I didn't get too into these. I don't care if you know that these work on the loop of Henle in the in the kidney. I don't really care so much about that, about like how specifically, like, right? What I want you to know is they cause sodium and water loss or excretion, right? And so they're going to help you to decrease that fluid overload overall. Furosemide is a real common one. That IDE, sometimes that helps you with knowing those different categories. Torsemide or some of the other medicines in that category, they end with that IDE. That suffix, I guess it would be. This is one that also secretes potassium. We need to make sure we're monitoring their potassium levels. When we see a patient on a lot of these hypertensives like hydrochlorothiazide or furosemide or these diuretics, if they're potassium wasting, we should also look to see if they have a potassium replacement ordered. Because if they're on these medications, most likely they should have a potassium pill supplement ordered that they're taking along with this. Because most people can't eat enough potassium to replace what they're losing. Then we also have potassium sparing diuretics. So when I say sparing, that means you're not wasting it, you're not getting rid of it, you're actually sparing it, you're keeping it inside of you. So you don't have to have extra potassium for these people because they're keeping it inside of them. So the potassium sparing diuretics, they're kind of more of a mild diuretic. They're not like the big guns. They might, somebody just needs a little bit help with diuretic, but they're worried about, hydrochlorothiazide might be too much, of a diuretic for them. They might start them on some of these potassium sparing diuretics. Spironolactone is a really common one. We also want to check for potassium for hyperkalemia, right? Because if their potassium is already kind of high and we're getting rid of fluid, but we're keeping the potassium, what's going to happen to our potassium level? It might go up a little bit. Probably not too bad, but if they maybe have some underlying kidney disease or something that's causing them to have a little bit of a higher potassium, that's something we need to watch for. All right, so that's kind of our diuretics. Now we're going to talk more about medicine that affects our heart with pressure. And remember, these medicines can be given for both hypertension, high blood pressure, or heart failure, right? Because sometimes with people with heart failure, we're trying just to decrease the pressure overall to help with that heart failure. So our, what did I say? Our sympatholytics, so beta blockers, they help to decrease the sympathetic nervous response, that fight or flight, right? So in fight or flight response, what happens? Heart rate goes up, blood pressure goes up, we're ready to go fight a bear or something. This helps to decrease that overall response. So the blood pressure is going to go down, the heart rate is going to go down. Metoprolol is a pretty good example medication. Beta blockers, the olol is a pretty good suffix. So if something ends with an olol, it's most likely a beta blocker. We need to make sure we're checking the heart rate and blood pressure before we give it, because it's decreasing that heart rate and blood pressure. We don't want it to go too low. In fact, before we get it, we're going to check the heart rate and what heart rate do we want it to be before we give it. 60. Above 60. Yeah. If it's below 60, what's going to happen to that heart rate? It's going to go lower. And then if that heart rate goes below 60, what's going to happen to our patients? Well, we don't know, but it's probably not good, right? It's probably not good things if we go too low. So we're going to hold it. Then we have our alpha-1 blockers. So they also help block that sympathetic nervous system, that fight or flight. But they also, it's more like the smooth blood vessels. So instead of constricting the blood vessels to get all that blood ready to go, they help to relax the blood vessels. And when our blood vessels are relaxed and more open, like that big balloon, what happens to the pressure? The pressure goes down, the more relaxed those blood vessels are. So prazosin is a really common medication for alpha blockers. Again, we want to check the heart rate and blood pressure before we give it. So we want to make sure it's too low. Again, these are not all of the nursing diagnoses. Nursing considerations. These are just the ones that are most common. Combine alpha and beta blockers. There's some medications that they take the beta blocker and the alpha blocker and they put them together. And if two medications really love each other, then they end up having a little baby. So anyway, carvedilol is one of the example combined medications. Catch that little olol, right? Because what kind of medicines live in olol or the beta blockers, right? Is this a beta blocker? Yeah, part of it, right? But it's important to know it's a combo. It's beta blocker and the alpha blocker. So again, we're checking the heart rate and the blood pressure. ACE inhibitors, guys, this is so fun. There's a whole lot that goes into how ACE inhibitors work. What I really want you guys to know is that they just help to decrease the afterload. So that afterload, remember that when you guys are going to blow up your balloon, that resistance, that's afterload. That's what the heart has to overcome, that pressure to get it out of the heart. So it helps to decrease that overall afterload. So with the ACE inhibitors, lisinopril or the prils, that's how you know it's an ACE inhibitor, because it ends up with the pril as its suffix. We want to make sure that we monitor for edema with heart failure. Sometimes it can cause a cough. And I'm not going to go super into it, but it's more about how it works with the angiotensin converting enzyme. There's this whole cascade of events that happen, but some of it is converted in the lungs. And when that happens, if somebody already has, because it's converted in the lungs, that can cause a cough. So sometimes people will have this cough that starts happening when they take the like lisinopril or other ACE inhibitors. Sometimes it's not too bad, but sometimes that chronic cough gets really bothersome and irritating, and we have to move them to a new medication. Did you have a question?
I was gonna say, yeah, so if it comes up, I guess, with that symptom on the problem, other state. Is it a common side effect and then it's expected?
Usually, if they're reporting the cough, it's enough that we need to change it. Yeah. Angiotensin 2 receptor blockers, or ARB. Those are the ones that usually end in tan, like losartan. And so those ones, they help to reduce extra fluid volume. So they're helping you to vasodilate. They're helping the vessels to dilate larger. And that helps to kind of lower that pressure. Make sure, again, that we're looking for edema with heart failure and checking to make sure their blood pressure isn't going too low. Calcium channel blockers. This one, I think it's so fun that our cells are so we're blocking calcium from getting into the cell, and that actually helps to cause vasodilation. Like, it's just, I love how our bodies work. So no, they're causing vasodilation. Amlodipine is a really common one. And we need to make sure we're checking the heart rate for if it's too low, check the blood pressure. Why are we checking for arrhythmias? Making sure they don't have history of arrhythmias. We're blocking calcium from going into the cells. So it means we're probably going to have more calcium outside of the cells. Remember way back last semester, we talked about fluid and electrolyte balances. One of the side effects of having too much calcium is that you can have cardiac dysrhythmias. If somebody's already at risk of having previous cardiac dysrhythmias and we're messing around with raising their calcium levels, this might not be the medication for them. Direct vasodilators. So this just relaxes the smooth muscles of the blood vessels. Hydralazine is a really common one. And again, I feel like a broken record. We're going to check for low blood pressure, low heart rate. Excuse me. Central acting alpha-2 agonists. So this one I think is interesting because it affects the nervous system centrally, like in the brain. So clonidine is another one of those. Ionotropes. So digoxin. Digoxin is one that we don't give a whole lot anymore. It used to be one of the really cardinal medications for heart failure specifically. Have you guys gone over digoxin in pharmacology? Mm-hmm. Yeah. You guys, and did she tell you guys that foxglove is where they get digoxin from? Yeah, I think it's so interesting to me that with so many of our medications, like we would have wise men or herbalists or people that would work in communities. And when they had issues, they would say, you know, eat this flower, eat this plant, you know, you are hurting, have this tree bark, right? There's so many medicines that are directly from nature or things that we like, that's what we've built things off of. And so anyway, I think digoxin's a really interesting one. So with digoxin, we know that it slows the heart rate and it really increases the contractility or the kind of the force of how the ventricles contract. Because it's slowing down the heart rate so much, we want to make sure we're checking that pulse, especially with digoxin. We check for a full minute. We don't check for 30 minutes and multiply times 2. We check for that full minute to see where the heart rate is. That's all I really care about with that one. Okay, so that's kind of a very quick and dirty with your medications. I have our classroom activities. I'll pull it up, but essentially it's the dice activity like we did the other day. So each group, so we just do table groups again. Each group will have 2 dice and you roll it. And the first person who rolls, you state what the medication class is. So you can be the one holding the page, right? And so you'll say, oh, I rolled a whatever, alpha blocker. Okay, so I got alpha blockers. And then you're the one that's kind of saying, okay, so Rena, what's the action? And Rena would say the action.
And then the next person, Jessica, would say, what's an example medication? And then Amy would say, okay, this is something nursing care I need to know about. Okay, you go through and then you hand off the answer sheet essentially to the next person who rolls. And then they kind of check everybody else. Does that make sense? Kind of a little bit, okay. All right, how about? Where's my little dice at? Will you take two and then pass them to the other tables? Oh, yeah? Maybe, yeah.
Find a Dungeons and Dragon app.
You don't need like an ATM to get the can if you hold it. All right, the dice will move around. How do you? I don't know. Annie?
That was like me.
Not problem, he will.
Yeah.
Everybody have their seats inside. Somebody else. So one person holds this. So you hold it and you roll the dice. Roll the dice. So eight is direct vasodilatation. So then you just kind of go around and whichever way you go. And so then let's see Taylor, what's a direct vasodilatation? So, yeah, and so you can help it out. Yes. And then we go to say.
There you go.
I draft, yeah. Yeah, almost all of them. And then once you're done, and you pass it on, and you go around.
Anyway. Yeah.
Oh, it's Anna Pearl. Pearl is yeah, I don't know how to say it. It's the nice.
What's the number?
And never include when I read the that we're not. Remember, right? That guy. So something. I know the medication. Butterfly, that's for both beta and. But I don't know.
Yeah, do they? They control the blood pressure, but inhibiting all those.
I'm so fat, but healthy.
Okay.
I don't know if I'm healthy.
And.
And. All right, so what is the mechanism of action? Sparing diuretic. It tells you right there.
You know.
Yeah.
But right now, we are.
Rena, what's that? Wait, they're having.